Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am happy to welcome you to the multimedia summary for the journal's December 2017 issue. I have selected 4 articles this month for Editor's Choice and Highlight articles. Our Editor's Choice is an original article that provides the first wide-scale survey of neurosurgeon diplomats of the American Board of Neurological Surgery that assesses perceptions regarding testing the aging neurosurgeon. It is authored by Dr. Maya Babu from the University of Miami in Florida and colleagues from UCLA Medical Center in Los Angeles, California, and from Mayo Clinic in Rochester, Minnesota. Motivated by optimizing patient safety, but without arbitrarily limiting the time during which an operating surgeon can practice, there is mounting interest in developing guidelines and processes within and by the profession to address this objective. The authors note that many surgeons continue to practice beyond the retirement age of 65, and that the number of surgeons older than 70 years approximates 20,000. Many surgeons surveyed who were older than 65 years and working beyond age 65 cited financial and personal reasons for doing so. Endurance, fine motor skills, judgment, and reasoning may diminish with age, but other skills, such as learned tasks and memory, can be preserved across individuals. Some studies demonstrate poorer outcomes for patients treated by older surgeons, but the authors suggest that poorer performance in aging surgeons may not be attributable to advanced age as much as it has to do with older physicians being less inclined to keep up to date on medical knowledge and advances. In this study, 1,449 physicians participating in Maintenance of Certification, MOC, responded to the survey. Participants in this survey included surgeons from diverse backgrounds, geographic locations, practice types, and age groups. Most respondents disagreed with an absolute age cutoff, but also believed that neurosurgeons age 65 and older should have MOC testing with more emphasis on practice, whether case-based teaching or individual case logs. The authors conclude that developing resources for institutions and colleagues to identify poorly functioning aging surgeons is important, and advocate for such decisions to be made on an individual basis. They propose that providing opportunities for aging surgeons to maintain meaningful involvement in healthcare is of the utmost importance. Importantly, they also note that the implications of these findings are widely applicable across other specialties. This article is accompanied by an editorial by Dr. Kerry Olson that broadly discusses the factors contributing to the decision to end one's surgical practice. Dr. Olson concurs that there should not be an age cutoff for performing surgery and recommends the following. Credentialing bodies should require surgeons to have regular physical examinations, and physicians should be encouraged to maintain overall good health. Surgeons older than 60 years of age should select a younger, trusted colleague to honestly assess their performance. All surgeons, regardless of age, should have periodic reviews of their outcomes. And finally, hospitals and clinics should embrace the opportunity of utilizing the knowledge, the expertise, the experience of many aging surgeons who wish to work in some capacity, such as performing less complex surgeries or assisting and teaching others in and out of the operating room. Our first highlight article is a consensus recommendation that proposes a conceptual framework for understanding unintended prolonged opiate use. This framework discusses 3 principal domains: the individual patient, the practice environment, and the opioid prescriber. It is authored by Dr. Michael Houghton from the Department of Anesthesiology at Mayo Clinic in Rochester, Minnesota, and colleagues from the University of Michigan Medical School in Ann Arbor, the University of Washington in Seattle, the University of Alabama at Birmingham, and the University of Pittsburgh in Pennsylvania. With rare exceptions, healthcare professionals with prescribing authority generally do not intend for an initial opioid prescription given for an acute pain episode to lead to indefinite repeated prescriptions. The authors closely examine this understudied entity of the transition from intended short-term use to an unintended prolonged opioid use. With regard to individual patients, the authors cite literature indicating that comorbid medical and mental health conditions may contribute to unintended prolonged opioid use. The authors point out that the etiology of pain may influence the risk of unintended prolonged opioid use after short-term use, and they discuss literature linking a preoperative history of substance abuse, alcohol abuse, tobacco use, depression, anxiety, and several pain conditions with unintended prolonged opioid use. The authors note that opioids are prescribed in a continuum of healthcare environments, ranging from independent practitioners to networks of hospitals and group practices, to fully integrated healthcare delivery systems, which are subject to regulatory oversight of various state and federal agencies. Unintended prolonged opioid use could thus be influenced by the practice environment, including the roles of various clinicians in prescribing opioids, adoption of relevant practice guidelines, and clinician incentives or disincentives, as well as the regulatory environment itself. As regards prescribers, characteristics inherent to individuals or groups of prescribers that may influence these behaviors include specialty or training in pain management and opioid use, personal attitudes, knowledge and beliefs regarding the risks and benefits of opioids, and professional norms in perceived obligations and approaches to patients stemming from the context of the former training or current practice environments. In conclusion, the authors propose this conceptual framework as a way of bridging together these three essential domains, namely the patient, the practice environment, and the prescriber. And they hope that this framework may guide future research on this topic that will ultimately minimize the incidence of this overarching problem. The second highlight article is an original article in which the authors evaluate the prevalence of monoclonal gammopathy in patients with wild-type transthyretin amyloidosis, the latter previously called senile systemic amyloidosis. It is authored by Ms. Hallie Geller and colleagues from Brigham and Women's Hospital and the Dana-Farber Cancer Institute in Boston, Massachusetts. Monoclonal gammopathy of undetermined significance is caused by overproduction of specific immunoglobulin proteins by a clonal population of plasma cells. Monoclonal gammopathy of undetermined significance can progress to multiple myeloma or other related plasma cell disorders, including light chain AL amyloidosis. A few prior reports have noted a higher than expected prevalence of monoclonal gammopathy in the wild-type transthyretin amyloidosis population, but this finding has not been precisely defined. While both wild-type transthyretin amyloidosis and AL amyloidosis can lead to cardiac involvement, determining which is responsible is important. This retrospective study included 113 consecutive patients with wild-type transthyretin amyloidosis seen at Brigham and Women's Hospital Cardiac Amyloidosis Program between 2006 and 2016. Wild-type transthyretin amyloidosis was diagnosed on the basis of a positive biopsy and or positive technetium pyrophosphate scan along with typical echocardiographic or magnetic resonance imaging. Monoclonal gammopathy was detected using serum protein electrophoresis and immunofixation and serum-free light chain assay. Light chain monoclonal gammopathy was defined as an abnormal serum-free light chains and an elevated free light chain ratio in the absence of a monoclonal protein. Renal function was documented in these patients, as renal dysfunction can lead to increased amounts of free light chains in serum. Monoclonal gammopathy was detected in 26 patients, or 23% of the population studied. Of these, 24 had a monoclonal protein in their serum, and 2 met the criteria for light chain monoclonal gammopathy. There were no significant differences between the patients with and without monoclonal gammopathy, except for the levels of the involved elevated free light chain and free light chain ratio, which, as expected, was significantly higher in patients with monoclonal gammopathy. The authors conclude that the finding of a monoclonal gammopathy with or without an abnormality in serum kappa lambda free light chain in an elderly man with clinically isolated cardiac amyloidosis should not be taken as prima facie evidence of light chain AL amyloidosis. The 23% prevalence of a monoclonal gammopathy in patients with wild-type transthyretin amyloidosis underscores the importance of precise tissue typing of the amyloid deposits, especially in equivocal cases. The third highlight is an original article that utilizes the Rochester Epidemiology Project record linkage system to evaluate the incidence of sarcoidosis and risk of multimorbidity involving 8 chronic conditions. It is authored by Dr. Patapong Pransert from the Division of Rheumatology at Mayo Clinic in Rochester, Minnesota, and Mahidol University in Bangkok, Thailand, and colleagues from the Divisions of Epidemiology, Biomedical Statistics, and Informatics at Mayo Clinic in Rochester, Minnesota. In this population, patients with sarcoidosis had a significantly higher risk of developing multimorbidity than sexed and age-matched individuals without sarcoidosis. The authors distinguish multimorbidity from comorbidity, stating that in the traditional comorbidity model, an index disease is defined generally and considered as the most important entity, and the co-occurrence of any additional disease entities less so, while the concept of multimorbidity regards all morbidities of equal importance. This study used a previously identified cohort of 345 cases of incident sarcoidosis diagnosed between 1976 and 2013, a cohort of sexed and age-matched comparators without sarcoidosis at the time of the patient's diagnosis of sarcoidosis was randomly selected from the same population. The median length of follow-up was approximately 13 years for cases and 16 years for comparators. A significantly increase of risk of multimorbidity was found after the diagnosis of sarcoidosis. The risk appeared to be particularly high within the first 5 years of diagnosis, suggesting an acceleration in the occurrence of comorbid conditions after the occurrence of sarcoidosis. The authors suggest explanations for the increased multimorbidity risk. They recognize that patients with sarcoidosis have an increased inflammatory burden, and chronic inflammation is linked to an increased risk of several cardiovascular and other morbidities. In addition, the increased incidence of multimorbidity could be a complication of glucocorticoids, the latter commonly used in the treatment of sarcoidosis. The authors note that the increased risk of developing one of these morbidities could be a result of shared predisposing factors. The authors also consider that the increased incidence of multimorbidity could be a result of surveillance bias, as patients with sarcoidosis may have more medical examinations and laboratory investigations because of their sarcoidosis. Finally, the authors conclude that these findings reflect the increased healthcare burden of sarcoidosis and serve as a reference point for patient management and healthcare policy. As always, you can access these highlights and editor's choice articles free of charge during the entire month of December. If you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, You will find other free content such as our Path to Patient Image Quiz, Art at Mayo Clinic, stamp vignettes on medical science, and interesting medical images. Mayo Clinic Proceedings also offers access to our social media, which you may access by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel, where you'll find videos of full author interviews, our 60-second video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which is available from our website on the home page, as well as through iTunes. And, as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.